What are the blood parameters like in rheumatoid arthritis? There is elevation of acute phase reactants, also called APR. C-reactive protein CRP of more than 4 milligrams percent is the single most useful marker of acute response to inflammatory injury to the joints. A raised ESR of more than 30 milligrams is also seen, but we know ESR has got several other confounders. Serum ceruloplasmin level, which again is an acute phase reactant, is elevated. Serum haptoglobin, called the HP, is also elevated in acute rheumatoid arthritis. Leukocytosis, neutrophilia, normocytic normochromic anemia. Here, the degree of anemia indicates the severity of the disease. Thrombocytosis may also be seen. So, these are some of the blood changes in rheumatoid arthritis. What is the synovial fluid like in rheumatoid arthritis? There is no need in general to aspirate joint fluid for diagnosis, unlike in gout, where the diagnosis, confirmatory diagnosis, rests on aspirating the joint fluid and demonstrating the urate crystals. Here, it is not. Joint aspiration is not a must for diagnosis, but it may be required to do for two reasons. One, to exclude other causes of arthritis. Two, to inject corticosteroids. Other than that, there is no need for joint aspiration. Inflammatory arthritis picture will be seen in the form of turbid fluid with reduced viscosity, increased protein content, decreased glucose content. WBC may range from 2000 to 50,000 per microliter. Polymorphonuclear leukocytes predominate, total complement is decreased, markedly depressed C3 and C4 because of antigen antibody complexes and consumption of the complement at the level of the joint, on the joint synovial fluid, synovial membrane. So, these are the changes in the synovial fluid and rheumatoid arthritis. The commonly used test by all of us for rheumatoid arthritis is rheumatoid factor, and we need to know a little bit about this particular test. This is developed by Eric Waller in the year 1937, and it was earlier called as Rose-Waller test. Rheumatoid factor examines agglutinating antibodies using latex particle agglutination assay. Newer type agglutination assays use specific isotype enzyme immunoassays. These are new techniques. Rheumatoid factor is antibodies to the Fc portion of our own immunoglobulin. Our immunoglobulin has got two components, the Fc portion called the constant portion, the FAB portion is the variable portion. So, here in this particular disease, there are antibodies developed against our own immunoglobulin. So, these are anti-IgG antibodies, and these antibodies are of the class of IgM. Sometimes IgA also may be there, but mostly rheumatoid factor antibodies are IgM antibodies against our own immunoglobulin G, the Fc portion. Rheumatoid factor is positive in 5% of the normal persons also. So, there are false positives with rheumatoid factor, and in only 70 to 80% of rheumatoid arthritis patients, we see this being positive. The remaining 30% of the cases of rheumatoid arthritis do not show rheumatoid factor, and this is called a situation seronegative rheumatoid arthritis. So, there are a lot of false positives because of low specificity, there are a lot of false negatives because of low sensitivity. So, we cannot conclude if the rheumatoid factor is positive, we cannot say it is definitely rheumatoid arthritis. We cannot exclude the disease if the rheumatoid factor is negative. So, there are a lot of false negatives and false positives. It is not a screening or diagnostic tool. Then what is the use of this test? This is a prognostic tool. A patient who has got rheumatoid factor positive, he is in serious disease, and as the disease activity comes down, we see a drop in the rheumatoid factor levels. So, this is more a prognostic tool than a diagnostic tool. Rheumatoid factors are commonly seen in other diseases also. So, what are the other diseases other than 5% of normal individuals? In some other rheumatological and non-rheumatological diseases also, we see elevation of rheumatoid factor, and that is listed in the next slide. In advanced rheumatoid arthritis with joint deformities, with rheumatoid nodules and all the full-blown picture, almost everybody will be positive for rheumatoid arthritis. But the overall positivity in rheumatoid arthritis is only 70%, 30% of the cases of rheumatoid arthritis being negative for rheumatoid factor, they are called seronegative arthritis. Sjogren's syndrome, which is keratoconjunctivitis sicca, a manifestation of eye manifestation of rheumatoid arthritis with dryness of the eyes, and in that case rheumatoid arthritis for rheumatoid factor is positive in 90% of the cases. Systemic lupus erythematosus, 30% of the patients may be positive for rheumatoid factor. Seborrheic bacterial endocarditis SABE, 40% are positive for rheumatoid factor. In tuberculosis, 15%. Old age itself, the rheumatoid factor may be positive in around 20% of the patients. As I told you earlier, 5% of the normal healthy individuals might also throw a positive rheumatoid factor test. So, the test specificity is low, sensitivity is also low. The specificity is much lower. So, a false positive test and false negative results confound the interpretation. Then what is the answer? A relatively newer test called Anti-CCP antibody test in rheumatoid arthritis. In this part of the world we say it is Anti-CCP. In United States they call it as antibody against citrullinated protein. Anti-citrullinated protein antibody ACPA, and we call it as anti-cyclic citrullinated peptide antibody or anti-CCP. CCP stands for cyclic citrullinated peptide. Citrullinated peptides are generated in the synovium by the enzyme citrullinated peptide related enzymes, and these produce CCP, and antibodies are generated against these citrullinated peptides on the synovium. The similar in sensitivity for rheumatoid arthritis, just like the rheumatoid factor, 70% sensitivity, whereas specificity for rheumatoid arthritis is better, 95% better, whereas that one is around 85%. So, better than rheumatoid arthritis for specificity. Specificity means it rules in the disease. Sensitivity, specificity rules out the disease, and sensitivity rules in the disease. In early polyarthritis, anti-CCP are very useful for diagnosis. Anti-CCP are associated with more severe disease. It's again a prognostic factor. A patient having anti-CCP and rheumatoid factor will have a much more faster downhill course, and he will present with severe manifestations. They spell a poor prognosis and rapid progression. They may be positive in asymptomatic patients years before the onset of symptoms. So, anti-CCP has got another role. It can predict who are going to become candidates for rheumatoid arthritis. So, this particular antibody is positive years before the rheumatoid arthritis manifestations, either acute or chronic, develop. This table summarizes the utility of these two tests, rheumatoid factor and anti-CCP. The specificity of rheumatoid factor is 75%, whereas sensitivity is 60%. Anti-CCP specificity is 96%, sensitivity is 75%. Suppose we combine both and insist that to look at both the tests, then the specificity will go up to 99%. That is, a person who is negative for anti-CCP, negative for rheumatoid factor, for both, we can say he does not have rheumatoid arthritis. Whereas, if a patient is positive for both, the certainty of ruling in the diagnosis is 80%. Rheumatoid factor is an IgM antibody to the Fc protein, as we have already discussed, Fc portion of the immunoglobulin G, whereas anti-CCP are antibodies to cyclic citrullinated peptide. So, this is a nutshell about the serology of rheumatoid arthritis. In the next slide, we look at the differential diagnosis of rheumatoid arthritis.